All right, well, thanks for coming.
Okay, I just started recording, so I'm going to leave.
So I'd like to welcome our speaker today, Dr. Karl Richardson. Karl is an assistant professor in the section on cardiology and a future associate program director in the Department of Internal Medicine residency program. His research interests include assessing quality of clinical reasoning and documentation, and that's a project he's been working on with Dr. Cindy Burns and Joey Cristiano, and something that he hopes to continue working on in his role with the residency program moving forward. He obtained his bachelor's degree in science from Vanderbilt University and his medical degree from the University of Pennsylvania. He also did his internship in residency in internal medicine at the University of Pennsylvania and then went back to Vanderbilt for his fellowship in cardiology. And we are lucky enough to have Karl here with us for the past few years. And on behalf of the Department of Internal Medicine, please join me in welcoming Dr. Richardson.
All right, can you hear me on this thing? All right, so I'll start by saying I was stressed out about this talk. I talk a decent amount at this type of forum. Is that one supposed to be lit up? Oh, okay. But I really wanted to do something different, so you probably think, well, he's going to talk about what are the different types of stress tests and then how we choose which one to order, and I'm not going to go there at all, so stay tuned. I read a lot for this talk too, and I stumbled on this brilliant quote, which I think sums up the whole talk. All right, so we start. Starts with the case. 54-year-old lady, hypertension and GERD, and she comes into your office, we're talking about outpatient stuff here, with atypical chest pain for the last 5 months. She says, sometimes it's worse with exertion, sometimes it feels like an ice pick. And I'm sure you have a patient like this before. You're like, an ice pick? Really? How did you get the ice pick? She is a former smoker, but she doesn't smoke anymore. And so I think there are three typical scenarios that you're trying to sort out. And these are the cath-based scenarios. I think it's important to think about the coronaries when you're thinking about the scenarios because that drives your management. So the first thing you're trying to decide here is you're trying to say, well, is this stable coronary disease, meaning a blockage, 70%? She feels something when she exerts herself, it goes away when she doesn't. Is this non-cardiac chest pain, meaning her coronaries are totally normal? Or is there something acute that's happened, ruptured plaque in the coronary? You can see this coronary has like a 95% blockage there, and then something sitting in there that's thrombus or plaque that's ruptured. And your first question here is, I'm going to take this off the table. I think most of us say, okay, well, this is an ACS. Now I'm stuck. Non-cardiac chest pain, or is it cardiac chest pain? Well, I'll just stress them, right? And that's where we are. So that kind of sets this up. These are my objectives. Started out with I want just people to walk away from this talk appreciating the history of cardiac stress testing and the genesis of imaging. Try to employ a clinical decision algorithm for ordering stress testing. Explain some of the clinical reasoning pitfalls associated with stress testing. And the risks associated with it, discuss the prognostic implications of stress testing, and then hopefully, after leaving the talk, you'll be able to apply the results of stress testing to some clinical situations. This is what I think a lot of people think about stress testing. I know not everybody thinks this, and I've used this slide before in a different talk, but I think this is what people think, is you have chest pain, you get a stress test, it's negative. And I say some people, not everybody. Stress test is negative, the patient's happy. And if it's positive, straightforward, they go to cath. And if that's negative, they're happy. And if it's positive, they get a stent. And then in that case, they're happy. So pretty much regardless of what happens, if you have a patient with chest pain, you can send them to a stress test and they'll end up happy no matter what. And you will too. And I would say this would be more straightforward if stress testing was more accurate, which unfortunately it's not. And if fixing coronary stenoses, and this is an important one that I'll talk about, if fixing blockages was proven to typically help. I'm going to sit here and try to avoid Dr. Gandhi and Dr. Tan that I can see sitting there, but they would agree with me. So let's start. Part one, history of stress testing. Here we are in the 1960s, 1970s. Angina can finally be managed. So Favillaro performs his first CABG in 1967. The next question was, okay, we can fix this. Can we identify that it is truly cardiac? Can we identify the cause of angina non-invasively? So I'll start with this. This is some of the very first bypass data, and this is a whopping 70 patients randomized to bypass or medical therapy who had obstructive coronary disease. And you can see what they found is that after surgery and follow-up, 69% of those operated on felt great, were asymptomatic, whereas those that weren't operated, only 11%. And they said, well, this works. And then, I love the bluntness, New England Journal back in 1975, dead. They said, is there something here? 14% of those not operated on were dead in follow-up, and only 9% of those that were operated on. So maybe there's something there, but this is early data, 70 patients. And then over the 70s, they kind of sorted this out, and this is a meta-analysis of bypass trials, 7 of the early bypass trials from the 70s and 80s. And you can see that, in fact, this is just looking at mortality. Bypass reduced mortality. And there's some interesting caveats to this graph. You say, well, look, it looks like it reduces mortality at 5 or 6 years, and then the curves kind of come together. The curves probably come together because 41% of the people in the medical treatment arm ended up getting bypassed. So somewhere along the lines, all these people, this is the black line, is those getting medical therapy who were starting to die, were probably getting bypassed and approaching those that got bypassed from the get-go. So, revascularization works. And then I put down in here the reductions in mortality for left main and LAD. And one of the reasons that I start with this is that since your stress test is designed to pick up things that can benefit the patient, and you're going to note this is the last slide I'm going to show you with a mortality benefit, you want to understand what the stress test is picking up and what that implies for your patient. So that's why I started with this. So here we are. Now we're in 1964, and the question was, I want to be able to identify coronary disease, obstructive coronary disease. So the first question was, we need something that we can image non-invasively. And of course, they were playing around with radiation back in the day. I wasn't there, but that's what I hear. And so they said, well, what if we injected something radioactive, and then the heart could pick it up, and we could just image that externally? And so they played around. This is the dogs. This is cesium. They were thinking potassium analog, sodium potassium ATPase. That should work. So they gave these dogs radioactive cesium, and then they imaged them. And you can see in this picture right here, they found that if they imaged the dogs, a bunch of counts, a bunch of radiation was emitted from roughly the area of the heart and the liver. And then they asked a very logical question. They said, well, that's where all the blood is. How do we know we're not just imaging the blood? Well, you just cut the dog's heart out, dump the blood out, and then re-image it, and that's what this was. And so then they said, huzzah, here we are in 1964. We can, in fact, image myocardial uptake of cesium. Then the question was, well, what if we ligate the LAD? The LAD is the main coronary on the front of the heart. I put this anatomical picture here. What if we ligate the LAD and then image the dog? Sure enough, you can see the counts aren't there in the anterior wall of the heart. They'd sorted it out. They did the same thing, cut the heart out, dumped the blood out, imaged again. Yes, in fact, there was no radiation coming from the apex of the heart, and in fact, that happened to be the part that was all infarcted. So there we go. We figured it out. We can, in fact, non-invasively image infarct. They did this in humans, too. Same study, I believe, yeah. They took a volunteer from the lab, which is what you did back in the 60s, injected them with radioactive cesium, and then this is one of the pictures. You can see the heart in a nice, relatively solid distribution, shows uptake, and then, of course, the liver as well. And then they found somebody who had a big anterior infarct based on Q waves. They didn't cut the heart out. They already knew that the tracer was being taken up by the myocardium, and they imaged them, and sure enough, absent uptake there. Got a little better. A few years later, they started using potassium instead of cesium. And here what they're doing is they're saying, well, yes, we can image these people in one plane, and we can sort out that there's a defect. But is it possible, how do we know the defect's coming from the front of the heart, not the back of the heart? So what they did is they said, well, we'll image them in 2 planes and try to sort it out that way. So this is an example of a normal, not stress test, but just nuclear imaging. And I'll show you what goes on here. So here, this is somebody with an LAD infarct. And here in the anterior view, you can see this is the LED right here, and this is the circ. So the LED should run in here and the circ in here. How do you know this isn't circ disease? They said, well, we'll just, because you can see the absent counts right here, we'll just turn the patient over and image them from the other side, where the LED is on the left of the screen and the circ's right here, and the LED's gone. So they said, okay, it's an LED infarct, so we've got that kind of sorted out. Shortly thereafter, they started saying, well, now we can image infarcts, but who cares about infarcts? What we really care about is getting that benefit that we saw in the bypass data. So can we image ischemia? And so they started doing this. And of course, they were already imaging ischemia with EKG. The question was, had they found something better? And it turns out they had, and I'll show you. This is an example of somebody who, at rest, in the anterior and LAO projection, these are the two different projections, they look normal. You'll just have to agree with me that that's normal. And then with exercise, you can see they lose counts here where the RCA is, and then when they flip them over, they lose counts where the LED is. And so they said, okay, let's cath them and see if that correlates. Sure enough, 95% RCA blockage here, and the LED, which is right here, was 100%. In the early data, you'll just have to trust me. But then they had found out that, in fact, they could image it. And within the question was, is it better than EKG or not? And early stress testing that wasn't particularly sensitive, but highly specific, very blunt, if you saw something that was whoppingly abnormal, showed that it was roughly equal to EKG, not a very sensitive test at the time, very specific, for multi-vessel disease, two-vessel disease, but one-vessel disease, which of course at times can be important if it's the LED, nuclear imaging was better. So they were excited. And then the real kicker here is not only could they see it at rest, could they see that with exertion, this person I think is doing a hand grip test, where they're just kind of going like this until they get angina. You can see that the counts go away. The really important thing here was, well, let's operate on this person and then re-image them when they're going like this, and it gets better. So they said, well, look at this. Bypass improves mortality, it improves symptoms, and now we can see that all from a nuclear perspective. Isn't this excellent? And this can help our patients. Now, of course, around the same time, cardiac imaging was taking a number of leaps. I'm an echo guy, as many of you guys know. I couldn't put up imaging here. And is Jonathan Brock in the room? He's not, probably, because he's being forced around in the cardiology service. He told me, he wasn't sure if he was going to be making it, but he told me to put this slide in here, so it's his fault. This is M-mode imaging. This is the first stress echo I could find. 1977, this was done a few years before that, though. And what M-mode imaging here is, and I'm going to show you this a couple times here, this is the control, this is during pain. So they took the patient, they said, okay, here's the hand gripper. Start going like this until you get chest pain, and we're going to image and see if we can detect that. And then this is after testing. I'll show you what M-mode imaging is. This is a modern ultrasound where we have both 2D and M-mode. But what M-mode is, it's looking at a single dimension of echo over time. And what you can see here is as the septum, which is up here, is squeezing, the image here goes up and down with the septum. You guys follow that there? It's Jonathan Brock's fault. He said to include it. So then if you go back to this, you can see at baseline, the person had nice septal movement. And then with stress, they were like, oh my goodness, two things happened. First, the cavity, the distance between the septum and the posterior wall got bigger. That's a problem. The person's LV is dilating with stress, and the septum isn't moving very much. And then the patient's going, I'm having chest pain, can I stop? And they say, yes, stop. Oh, it gets better. Okay, we've just detected ischemia. A few years later, the stress echo was getting better. You can see this is from 1979. They're actually using something more like what we would see now. And then the imaging got better. And the idea with stress echo here is just to see if you can detect a wall motion abnormality. Of course, I can't show you a wall motion abnormality because there wasn't video that they could put in the papers at that point. And similar to nuke, the question was, okay, we've found this. Is it really better at all than stress EKG? And this is prognostic data, but it gets the point across, which is that they can find stuff that becomes relevant for the patient. This is stress EKG, prognostic discriminatory value of normal versus abnormal stress EKG, and then this is stress echo, and you can see that those that had abnormal stress echoes were doing worse, so they were probably finding stuff that was more important. So that's where we were. Severe, symptomatic CAD benefits from revascularization. We knew that. Stress imaging can detect it better. But the important thing to remember is this is a blunt instrument at the time. 15%, depending on the study, even more than that sometimes, had to be abnormal for it to be considered an abnormal test, and then to take you down the path of eventually providing maybe even a mortality benefit for your patient. It wasn't what we have nowadays. Stress imaging has improved over the years, so the resolution improves dramatically. The ability to detect, there's Jonathan Brock. I just blamed you for a slide. You've just missed it. Stress testing improved. We use technology to sort out whether or not there is ischemia or not. We can use cardiac MRI to really detect some really tiny stuff, infarct and ischemia. We can use PET to sort this out. All sorts of interesting things. And of course, stress echo has improved as well. We've gone from that really brutal M-mode imaging or not terribly resolute 2D imaging to these really high-end studies where we can look really closely at the endocardium. And look, this is a rest image here, and this is during stress. And when we read stress echoes, we just see, is there a tiny wall motion abnormality, or a big one, or not with stress? And that's how we sort this out. So the current dilemma, though, is stress testing is everywhere. We have this fear of missing a cardiac presentation, and I understand that. We, of course, appreciate that. And there's more testing in non-cardiac patients. So where we are now, stress testing has taken off. We can stress people that walk and those that don't. We can stress people with known disease and those without disease. We can stress patients that have almost maybe those that would benefit from revascularization and those that wouldn't benefit from revascularization. So we have a lot of options. And I think it's important to note that we have an increasingly sensitive test that may be yielding results that lack data to support the benefit. And what's happened here is that we've gone from our storied past, which is this, and we've departed from it in two ways. One, we've brought the test to an increasingly non-cardiac population. And two, we've brought it to a group that may not stand to benefit as much from revascularization. This is where we were, and I think this is where we are nowadays a little bit. This plays out, so courtesy of one of my co-fellows at Vanderbilt, this is, I think, an interesting example of this. So here we have unofficial Vanderbilt data, not published. One of my fellows, Arpit, looked at this, my co-fellows, and he said, okay, let's look at all this stress test coming out of our ED at Vanderbilt. 295 patients stressed. These were all nukes from the ED in, I think, 2014. Of those, there were 38 positive stress tests. 35 of them proceeded to the cath lab. We all know almost everybody with a positive stress test goes to the cath lab. Whether or not they should is another question. 3 had true disease. The positive predictive value of that is really low, and probably because, who gets stressed from the ER? And I'm not blaming the ER. I think this is a systemic issue, is in part these young people. So, part 2, deciding to stress. First issue here is you have to understand the characteristics of the test that you're ordering, and you have to understand the pretest probability of disease. So start with Bayes. Who is Bayes? He's an English mathematician and a minister, a Presbyterian minister. I feel like they all were back then. And he had an interesting question. He said, I don't want to just know the probability of something occurring. I want to know the probability of it occurring if the likelihood of it occurring varies. So, for example, I don't want to just know the likelihood that it's going to rain today. I want to know the likelihood if it's going to rain in January on a cloudy day in northern England. So, see, the pretest probability of rain depends on where you are in England and what time of year it is and how much clouds there are. But this was his interesting question. Stress testing relies on this similar theorem. It's not 100% sensitive and specific. The utility of the test that you're going to apply depends on the pretest probability. And I put this graph up here to try to answer that. So you're not just saying, does this person have obstructive disease? Please, stress test, answer that question. You're saying, assuming the patient has a pretest probability of X, how will the positive or negative result that I get from the stress test affect the likelihood that the stress test is true. Just let that settle in for a second. And so, the sensitivity and specificity, as they improve, the red lines here suggest a really sensitive and really specific test, which says that in a really good test, no matter what your pretest probability is, if the test is positive, let's say if your pretest probability is 0.5, 10%, the test is positive, your post-test probability is 90%. That person definitely has obstructive disease. And even if your pretest probability is way up here at 65, it's still positive. And if the test is negative, down here, no matter what your pretest probability is, a negative test result will be suggestive of a true negative. Unfortunately, a lot of the tests look more like this, suggesting there's not as much discriminative power as what we want, saying that if our pretest probability starts down at 10% and the test is positive, our post-test probability is still well less than what we'd be worried about, 20% or so. So that's a lot. I'll come back to it in just a second. What is the sensitivity and specificity of imaging? You can see standard treadmill, sensitivity of 68%, specificity of 77%. If you add imaging, a nuke has a pretty solid sensitivity, 90%, but lacks in specificity. So that means that it will find something if it's there, but when the nuke comes back with mildly abnormal yada yada, there's a decent chance that that's a false positive in the wrong population. Stress echo is a little bit of the opposite. Sensitivity is not as good, meaning it's less likely to find small stuff that is there. But the specificity is really high, which means that, well, not really high, but it's solidly high, which means that if it does find something, it's likely to be a true something. Cardiac MRI gets even better, and I think at some point we may be employing more cardiac MRI. Logistically, we're not quite there yet. This is what nuke and stress echo looks like. So you can see nuke, I told you the sensitivity is a little better, which means if you get a negative test, you can somewhat rely on that result. But a positive test with a nuke doesn't affect your pre- and post-test probability as much as you want it to. Stress echo is the opposite. Negative test is not quite as useful. A positive test is a little bit more useful, but still not amazing. Now, I think we're actually better at this than we give ourselves credit for. So with a chest x-ray, the sensitivity and specificity is low, but it's kind of reminiscent of stress echo. And we probably all the time say, I've heard residents say this all the time, oh, the chest x-ray showed this, that, or the other. I'm not worried about it. Or the chest x-ray was totally negative, but I'm convinced they have a pneumonia based on their clinical presentation. So we actually do this all the time. And I kind of start to wonder, I said, well, what if we reported stress tests like this? There's a low or intermediate probability that this is a true positive. Or what if we reported it back like a chest x-ray is? Would this change the way we think about stress testing? If we said, positive for ischemia in the mid-lateral wall consistent with ischemia or artifact, clinically correlate. But you know, that's actually what we're doing. We're just, being cardiologists, we're more confident than that, and we just say there's ischemia in the lateral wall. So, here we go. Let's take a really good test, pregnancy test, and see what the math does here. Sensitivity, 97%, specificity, 99.5%. You guys know the movie? Somebody shout it out. I can't even remember the name. Junior. Arnold gets pregnant. The utility of the test depends on the pretest probability. So the math starts. Here we go. So let's just say, indulge me, as my wife would say. Indulge me that 1 in 100,000 men is truly pregnant. So the test is going to pick up that man 97% of the time. That's the sensitivity. But of the remaining 99,999, the test accurately identifies most of them, 99.5, as not being pregnant. But 499 men are going to be convinced that a pregnancy test is a useless test because it's going to identify them as positive. And based on the 99.5% specificity, amazing specificity, there will still be 499 of 500 of those tests will be false positive results. We shouldn't walk away from this and say pregnancy tests are useless. We should walk away from it and say, Well, we used it on the wrong patient. So how do you sort out pretest probability? A number of ways. Back in the day, Diamond and Forrester tried to classify this. They said, well, we can take the clinical picture, the history, and the age of the patient, the sex of the patient, and sort out how likely they are to have obstructive coronary disease. So here you can see more risk factors you have, the older you are, the higher likelihood of pretest probability. You guys have probably seen this chart before, which is non-anginal chest pain, atypical angina, or typical angina based on the Diamond and Forrester classification. As you go up in age and as you go closer to what is typical, your risk of, or your pretest probability of disease is higher, and then you can use that to employ stress testing. You could use Framingham data and add blood pressure, cholesterol. You could do a lot of stuff here. And the data about how well we do this is mixed. So this is data from, I think, the 80s, where they said, we're going to send questionnaires out to residents. These were 104 residents, I think, at Rochester. And they said, we're going to give you a perfectly typical story for anginal chest pain and have them rank their pretest probabilities. And you might have heard the story and think they're all going to be right in this space, in the 70 or 80%. But turns out the residents had this total smattering of thoughts about the pretest probability of disease. Same with a non-typical picture here. Their answers were all over the place, suggesting that maybe we're not as good at estimating pretest probability, or rather, medical residents aren't as good at estimating pretest probability as we'd hope. And unfortunately, the computer algorithms or the models that we have don't work either, because this is just applying the Diamond and Forrester pretest probabilities and looking to see if there's actually disease. So if you have someone with typical angina who has, let's say, 1 to 2 risk factors for coronary disease, Diamond and Forrester would say their pretest probability is about 85%. But when you cast those people, the observed prevalence of disease is only 30%. So the algorithms don't really work either. But I don't mean to be down on it, because there's data to support, modern data, that says that residents get better at this through residency. So estimations of pretest probability improve with time. Attendings can do it better than residents. Internal medicine people do it better than emergency medicine people. And this is from the POEM literature. I found this. I think this is interesting. This is the utility of pretest probability estimations of the likelihood that a nodule will be malignant. You can put the characteristics of the nodule into a computer algorithm. That's what the gray and blue lines is. Or you can just ask a radiologist or pulmonologist, is it malignant? And them looking at it is better. So I say, and that's the red line here, this is area under the curve, the discriminatory ability of that test, of just having somebody look at it. So what this tells me is a couple of good things. We can learn to estimate pretest probability with exposure, and we can do it better than computers, probably. And what this to me says is we should spend more time recalibrating, which means you think something's going on, you test, we need to make sure we follow up on that test to see if we were right or not, so that we can recalibrate. I think this speaks to the importance of, for example, the night team getting feedback on what the admission actually was. So let's apply it to our patient. I've adjusted her age accidentally. I think it was 54 early on. Actually, my intention here was to do a different age now that I think about it. 45-year-old female with atypical chest pain. What do you guys think is the pretest likelihood that she has CAD? Someone shout something out. 10%. Oh, you guys are more pessimistic than I was. I thought you were going to say 2% because she's only 45. But let's just say she's got a decent story and you're kind of worried about her. She's otherwise young and healthy. Let's put her pretest probability at 5%. Of course, if I were to send the questionnaire out to all you guys, we'd see a smattering of pretest probabilities. Let's just say it's 5%. And when I've asked people who order stress tests, they often give me this result of 5 or maybe 10%. Let's do the math. So if you have 100 females, 5 have disease, we expect the nuke, I'm just talking about nuclear for a second, to catch all 5 of them, 90% sensitivity. But of the remaining 95 that don't have CAD, the test will be correct, that's the specificity, in 66. That means there are 29 false and 5 true positives. That means that 85% of the time that a nuke in a low pretest probability patient is positive is a false positive. That's a problem. Stress echo gets at that a little better. It's a little more specific test, but still, if you apply a stress echo to that same patient, and I would argue we do this all the time, 69% of the positive results will be false. We saw that in the Vanderbilt literature, not literature, but Vanderbilt unofficial literature as well. Part 3. So the problem, as you can see, in part, is these false positives. In a low prevalence population, you need a highly specific test, which we don't have, to avoid false positives. Maybe we do an MRI, sort of. And the problem is, even if you detect it, it's not straightforward. So maybe MRI isn't the answer. Maybe you need a blunter instrument. Because, and I'm going to show you here in part 3, why not just stress anybody? The worst case scenario is a cath, right? And the problem in part, though, is the unavoidable consequences once you've headed down that rabbit hole of stress, then cath, then stent. Now the patient's on meds, they can't get their knee replaced because they're on Plavix. And are we actually causing harm? And as an aside, I'll just say that how often do we order a stress test and the result comes back? We didn't think it was obstructive coronary disease in the first place, but now the patient has this positive stress test, and we say, well, I guess it was. Send them to cardiology. Forget entirely about the fact that the patient was saying, yeah, I just have this weird fluttering, and maybe we missed something entirely, because now we're stuck on this coronary issue. We go cath them, and then we stent them, and now you really do have coronary disease, and then they come back and see you, and they say, well, I don't feel any different, and I still have that symptom that I had that you didn't think was coronary in the first place. It's an interesting dilemma. And unfortunately, and I'm going to show you this, the story is murkier than we even think. So the positive stress, if it's negative, I think we're all happy with that. The cath, though, even if the cath is negative, patient might not be as happy as we think, because now we've said, okay, good news, it's nothing. But they're like, well, no, it was something. And if they get stented, that may not be the right outcome. And let me show you this. This is an example, a patient I saw on Monday, and I thought, oh, yeah, this is perfect. This is the perfect example of something that where this has occurred. Somebody ordered a stress test on this guy. He wasn't having any symptoms. Maybe they thought he was, but he tells me he felt fine. And it was read as positive. And I don't know how many cardiologists we have in the audience right now, but it may be positive. What it was read as is some apical lateral hypokinesis. And I think if you stare at it, and I look through a couple images, there is a subtle wall motion abnormality right here. So if you compare this image to this image, a lot of you probably look at it and say, it looks the same to me. But I think there's a subtle wall motion abnormality right in this space where it's not quite coming in. Joff is giving me a frowny face. Yeah, see? But this is what we're dealing with now. As we're looking at this and we're sitting there squinting in the echo lab, I think there's something there. I'll just call it a very mild defect in the apical lateral wall and let the person referring sort out what to do with it. Well, of course you know what's going to happen. The patient says, they go to the cath lab, and the cath attending document they're having some chest pain or something like that. Patient doesn't remember that. They got stented. And the patient says, well, good news. You know, he says, well, he goes, you wouldn't believe it. I wasn't feeling anything. They found a blockage, and they stented it. And gosh, that could have been awful. What if it hadn't been discovered? And that's what patients think. And so, but this is problematic. And so why does this matter? Anybody know what I'm referencing here? What's that? Did I hear it? Courage. The Courage trial. So, 2007, New England Journal, we asked exactly this question. So, now that we can find disease that is increasingly small, that our stress testing is getting better and better, and we're doing these casts and we're seeing these blockages, does stenting them help or not? And this included, 2,300 patients with a stress test that confirmed ischemia, a blockage that showed something, just like the patient that I had, and unfortunately didn't detect a difference in outcomes. No reduction in MI, no reduction in death at 5 years. This is a big deal. This blew up the cardiology world back in 2007, and there's some issues with this. There was a reduction in angina, and I think maybe, depends on how you look at it, there might be more benefit than we see, but the studied benefit of PCI is limited. And I think this is important to remember when we're thinking through what we're finding. This is the different arms here. You can see this is the composite endpoint. Note that in PCI there were more endpoints early on, probably because they had some early complications, and then they settled out, no difference in meds. Survival-free of ACS, survival-free of MI, overall survival, no difference. The story gets more poignant when you have this problem. Once you go to the cath lab and you see something, we have this thing called the oculostenotic reflex. And I have to say, I came from Vanderbilt, and to hear our interventionalists are really much better at this than elsewhere, where they see something and they say, that's nothing that's going to benefit from PCI, and leave it alone. Even more, sometimes I'm like, oh, why didn't you stent that? They said, nah, that's a bad idea to stent that. So I think we do this better. But in the general world, I think this happens pretty regularly, is that you see something, and now you're in the cath lab, and it's not the interventionalist's fault. They're there to find the blockage and to fix it. That's their job. But, of course, we sent them there, and through that rabbit hole. And it gets even more poignant with this. You could say, like the patient said, at least you fixed something that could have been a heart attack. But former chief of cardiology here, Dr. Bill Little, explored this. He said, well, let's take all the patients that have an ACS, a true plaque rupture event, and then let's go back and look at the cath data from some random cath that they had, year or months prior. And then let's look and see how bad that stenosis was that led to the heart attack. And you can see, and this is the percent stenosis pre-heart attack, you can see that the vast majority of the blockages before the heart attack occurred were less than 60%. So, gosh, stenting that 70% thing doesn't reduce the likelihood of MI, because most of the MIs come from stuff that's less than 60% or 70%. This is an example of that. This is a patient of mine who got a cath for another reason, and you can see right here, there's just a little bit of an apple core kind of look. A little tubular stenosis here, probably like 30%, 20%. And then the guy came back in 3 weeks later, lo and behold, he's having an anterior STEMI. And here in this image, and I actually have to go over here and click on it. There you go. Now you can see it's hazy in there. You see that? It's hazy because there's thrombus sitting in there, and that minor little lesion there has turned into an ACS, just suggesting to you guys that stenting will improve symptoms if you pick the right patient that's actually having symptoms, but it's probably not going to reduce your likelihood of having an MI. I'd like to think, as an aside, it'll reduce your likelihood of leaking troponins if you're in the medical ICU and you're in septic shock. But I don't even know if that's true. So, part 4. What do you do with the result? You might say, what's the point of all this? I love cardiology. And I should say also, as an aside, we're talking about chronic stable disease. ACS stenting is great. And I think that's played out really nicely. But you say, okay, what's the point? What do you do with the result? The first thing you got to decide is, now that you understand how stress testing works, is the post-test probability of disease convincing? And then the second thing that you can point out is, okay, we have a stress test, so let me think about what the stress test is actually good for. We know that imaging improves prognostication. The question that remains in the future is there anything we can do about it? So I'm going to delve into a little bit of this data, because this is, I think, what we have to live by if we're going to work with stress testing. So first we can say, yes, stress testing does improve prognostication, and it does it really, really well. So if you want to know what the likelihood of your patient dying is in the next 5 years, with thallium nuke, this is nuclear stress testing, and with stress echo, if you have a very positive nuke, which means that greater than 15% of the myocardium is abnormal, as compared to a, quote, negative nuke, which means that mildly abnormal or normal. And in all these studies, a mildly abnormal nuke was included with the normals because it's just a mild amount of ischemia, who cares? If you have a mild amount versus a lot, you'll do better. Same with stress echo. If your wall motion index is less than 1.4, meaning you only have maybe 2 segments that are mildly abnormal, you compare them to people that have a lot of abnormal segments, you do great. And again, I want to point out that a mild abnormality actually bodes really well. You do great. But what about more recent data? So this is a group of roughly 1,900 patients, good functional capacity, who underwent stress echo. And what they're looking at here is they say, well, let's take the number of severely abnormal segments, and this is stress echo, to see if we can understand prognostics. So if you have a whole lot of myocardium, greater than 25%, that's severely hypokinetic on stress, you have a bad prognosis. But if you just have a moderate amount of severely abnormal segments, it still discriminates from no severely abnormal segments. But I'll point out that if you had a mild abnormality, they left it in this 0. So the comparator is someone that has a normal stress echo or a mildly abnormal stress echo. And then this trial adds granularity to that. So it delves into the distribution of the ischemia to try to parse out that risk. So first thing they can say is, if you have an abnormal stress echo as compared to a normal stress echo, you can see it prognosticates really nicely. You have a rough few years ahead of you if you have an abnormal stress echo. But and I wanted to point out also that if you have multi-vessel disease on that stress echo, you have a really bad prognosis. So at 5 years, compared to a normal stress echo or mildly abnormal stress echo, 14.1% were dead as compared to 2.5. But if you try to parse out the vascular distribution of that a little bit more, and that's what they did here, if you have just single vessel disease and you look at RCA or CIRC, which are kind of lower risk distributions as compared to LED, you can sort out prognosis. And it turns out if you have a mildly abnormal stress test or even a moderately abnormal stress test but in a low risk distribution, your prognosis is great. So the takeaway from this is that if you have a patient with a small amount of ischemia or maybe ischemia in a low risk distribution, their prognosis is really good, comparable to someone with a normal stress echo. Would that change your management? I mean, that's a discussion you got to have with the patient. If they're having typical angina, you can improve their angina, but you got to keep in mind what you're getting at. This is the limit. This slide, I think, highlights the limited utility of stress echo in a low-risk population. So if you apply stress echo to people with a pretest probability less than 20%, this is really modern data, and you look at their prognosis over time, abnormal stress echo versus normal stress echo. Now, some of this is because if you had an abnormal stress echo, you went to the cath lab. And so you could say, well, we fixed them a little bit, but the COURAGE trial draws that into question. So I think this is poignant data. What you can say from this data is that if you have an abnormal stress echo, you're going to get revascularized. 95% of the people in this study, despite their excellent prognosis, went into the cath lab and got stented or went to bypass surgery, something like that. And I'd like to think that at least some of the reason why the prognosis didn't split at all is because we fixed something. But the data's not there yet. So even in patients with a high pretest probability of disease, greater than 70%, you can see that we've detected here multi-vessel ischemia versus single vessel and normal have similar prognoses. Well, rather, single and normal have similar prognoses, just like what I showed you a second ago. And if you have multi-vessel ischemia, you can see the curves divide. Interestingly, the way that you can make the curves divide even more is if you add this is death and MI here, but if you add revascularization, which means go to the cath lab, the stress echo prognosticates really nicely. That's kind of a complicated concept. Did you guys gather that? Let's see what I get for Got some nods, not a ton of nods. Point is here is that one way to discriminate what stress echo does is add revascularization to your endpoint. Dr. Burns is nodding, so that must be the So similar to echo, nuclear stress test has to be read with a little bit of a blurry eye. And so there is very limited data on what to do about this, but there is good data about prognostics, just like I'm showing you. So Berman, in 2004, tried to sort this out. He said, at what point does revascularization, at what point does a burden of ischemia affect outcomes? And he said that, well, it turns out if you have normal versus abnormal, normal is, well, this is two different models, but if you have normal versus abnormal, the number of segments that are abnormal on the nuclear study, after it crosses 4, is where your prognosis starts to deviate. So he set the line. He said, okay, good news, if you have 3 or less segments that are abnormal, your prognosis is roughly the same. It's not until after you have 4 segments that are abnormal does the prognosis head south. And then that plays out. This is a group of women who have abnormal stress echoes, and you can see that those with less than 5% abnormalities on their, not stress echoes, on their nuke, have a very good prognosis as compared to those that have greater degrees of ischemic myocardium. And so the takeaway here again is just to point out, if you have a mildly abnormal stress echo or a mildly abnormal nuke, the prognosis is actually really good. Turns out the best prognosticator, if you want to discriminate what someone's risk is, see how far they can go. So the best prognosticator, this is looking at the relative risk of death with regards functional capacity. So those people that you put on the treadmill and they go 13 mets, they are 1/5 as likely to die over the next few years as those that only go 1 to 5.5 mets. So if you really want to know prognosis, probably the best thing may be to look at their functional capacity. Here you can see what I put here is the hazard ratio. For each drop in 1 met, the hazard ratio is 0.84, and you compare that to the rest of these hazard ratios on here. So for example, we have a history of hypertension. Totally, your hazard ratio is 0.75, but if you go 2 mets difference, you've already way surpassed that in terms of prognostic value. I find this also interesting. If you want to know prognostic value, just ask yourself, what type of test did I order? If you ordered a dobutamine test, your prognosis is much worse than if you ordered a regular test. So if you want to know, you probably know the prognosis beforehand. Here, this is looking at annual event rate based on dobutamine versus exercise testing. And if the test is normal or abnormal, the type of test ordered actually discriminates better than anything else. So this is just another study looking at the same thing. But regardless of whether the test is normal or abnormal, it's the test that was ordered that discriminates best. So data on what a positive stress test means is really copious. So the prognostic data is abundant. And you have to remember, stress testing was validated based on this prognostication, not based on what it does to outcomes. There is a tiny amount of data on that, and I'll point this out here. So O'Keefe asked this first, Journal of Nuclear Cardiology, 1998. She said, well, let's look at those patients that had non-high-risk nuclear scans. So meaning they're not severely abnormal. And then take those patients and divide them into those that were medically managed versus invasively managed. And you can see, if you had a mildly abnormal nuke, this was back in the 90s, but you did much better than if you went to surgery or PCI. And then Hakemovich, apparently an epic in the nuclear world, he tried to sort this out even more. He said, okay, let's look at medical treatment versus revascularization and see if we can define the cut point. At what point does revascularization, which is the white bars, confer a mortality benefit or an event benefit over just straight medical therapy. So you can see if you have no ischemic myocardium and you get revascularized, you do much worse if you get revascularized compared to meds. And then if you have 1 to 5%, a little bit worse, 5 to 10%, a little bit worse, and it's at that point that finally revascularization makes more sense than medical therapy at around that 12.5%. And then he plotted these two lines here to show us that it takes about 12 to 15% ischemic myocardium to think that you're going to be doing your patient a definitive benefit by revascularizing them. And this will harken back to that really early data. Remember, bypass surgery, you had to have 15% abnormal, and had to be whoppingly abnormal, and then they found something, and they sent those people for bypass, and they did better. What about in asymptomatic diabetic patients? This is kind of an interesting study. They said, well, let's just take diabetic patients, and you probably have silent ischemia, and let's stress them all. Dr. Burns, once again, says this is not a good idea. Let's stress them all, and then see if that improves outcomes. And you follow them over time, and you can see that stressing these patients at year 0, followed over time, didn't change their outcomes. And this was just looking at, okay, what do providers do with this stress testing? Should we be stressing them or not? Obviously, the ones that had positive stress tests, a lot of them went to revascularization. Those that didn't carried on. I don't want to be all Debbie Downer, though. I don't think that coronary disease is irrelevant. That's not my point. I just wanted to put the data out there so that I can kind of reapproximate providers, which is you guys, with the tests that you're ordering. And I think that's part of the disconnect. This is data saying that no, there probably is some benefit to long-term survival if you fix coronary disease. And what you're looking at here is a very complicated chart. This is drawn up by the surgeons, so I blame them. But it's the only one I could find where it's looking at low severity versus intermediate severity and high severity. And you can see no matter how bad your coronary disease was in this data, and again, there's always competing data, no matter how bad it was, you did benefit from revascularization. And there is emerging literature about trying to sort this out better. So Dr. Gandhi and Dr. Tan would be familiar with this. The FAME-2 trial said, okay, well, we recognize that we shouldn't just stent everything, but if we can objectively define with a coronary wire how bad the stenosis is, then we can improve outcomes. And what they did here in FAME is they said, well, let's take patients who have a cath and who have what looks like a severe blockage. And then we'll put a wire past it and prove it's severe based on pressures. If the pressure drop across the blockage is significant, then it must be a severe blockage. And using that definition, if you then randomize them to fixing that blockage or treating them with meds, the people that are in the PCI arm do better over 3 years than those in the medical therapy arm. Keep in mind, the cumulative MACE here includes revascularization. So I kind of wonder if the people that were randomized to watching and meds, all those patients went home with saying, but I have a blockage, and they left it there, but I had a blockage, and they left it there. And then they come to the ER and then get urgently revascularized. But I think we are moving in the right direction here. And stay tuned. The ischemia trial, which is near ending enrollment. Have we stopped enrolling for the ischemia trial? Do any of you guys know? The ischemia trial is looking at this question. What's better? If you have mild to moderately abnormal nuke or stress echo, and you randomize those people to go into the cath lab or not, randomize them, how do they do? It's kind of modern application of this. And they're having a really hard time enrolling this because everybody who has a positive stress test goes to the cath lab. So they've been enrolling for as long as I can remember. But at some point, we may have an answer for you guys. So bottom line. Role of stress testing. I could title this risk of stress testing, but multivessel left main LAD disease benefits from revascularization. We know that. Stress testing can detect obstructive disease, but the diagnostic utility depends on the pretest probability. Stress testing has been validated as a powerful prognosticator. That is for sure. And mild ischemia can often be medically managed. With that, I re-highlight my objectives, and I'll take questions. Thank you, guys. Yes.
I guess one of the issues is in mild ischemia, when you find it and you're going to do medical management, when do you look again? When do you think you should look again?
Prognostically, I think you've sorted it out already.
But at some point, things are going to get worse.
Yes, well,
so do
maybe.
you go with symptoms, or do you just go with?
I think you go with symptoms. You follow the patient and you put them on a beta blocker, you put them on aspirin, you put them on statin. You say, bad news, you have coronary disease, but it doesn't look like it's bothering you that much. Or maybe it is. At some point, if it's bothering them a lot, you go to a cath lab. But if it's not bothering them that much, you say, well, look, we're going to try medical therapy on this. The good news is your stress test was low risk. Mild ischemia in the lateral wall, mild ischemia in the inferior wall, focal ischemia in the mid-apical wall, that type of stuff. You can say, hey, good news. Low-risk stress test. I do think you have coronary disease based on my understanding of your pretest probability of disease in the first place and my belief that the test was positive. And we're going to put you on an aspirin, put you on a statin, and follow you. If your symptoms are crescendo, then it is probably time to go to the cath lab. But, for the patient that you thought, this wasn't coronary to begin with, and they have some dyspnea on exertion, that patient, I think you can give them really good news.
Carl, that was a really great talk.
Thank you.
A lot. One of the points you brought up was about looking at sort of attending gestalt of the pretest probability, and you brought up two cases, one of low-risk chest pain and one of pulmonary nodules. Those were older studies, and in fact, it seems like in this day and age, most of the people doing that kind of ordering, of going down the rabbit hole, are not cardiologists and they're not pulmonologists. So what's the way out in this RVU-driven world where hospitalists are caring for 60 patients at a time, the emergency room is packed full? What kind of tools are available to help with this?
Well, that's a really good question. And, the reality is you are sitting in the clinic and there's a positive stress test, and who better to sort out the risk of that than a cardiologist? And I think some of that's on us, that when we see the patients in clinic, to be focusing on benefits versus risk of going forward with cath, for example. But I also think, and my point of putting that up there is empowering the provider from the get-go with the knowledge of what the positive result is going to give them. So, for example, if you're sitting there and you say, I really don't think this is coronary, then maybe you rethink ordering the test in the first place. Because your point's a really good one, and you're pointing out there is, in fact, a risk of ordering it in the first place. Once you have the result, you are kind of stuck. And then you can choose to medically manage. I had a primary care doctor email me the other day and say, hey, I got this stress test. I really don't think anything coronary is going on, apical ischemia. What should I do? And I said, hey, the good news, the low-risk stress test. Tell the patient who's a diabetic that they probably have some coronary disease, but we should sit tight on it. 8 months later, she's in my clinic, and we're trying to decide what to do. But it's a really good point. And I think understanding the test from the get-go and deciding to order it or not is where we have to change our mind.
I was wondering about medical therapy in the early studies versus medical therapy today.
It's a good point. I think that we have, and that's why the ischemia trial is ongoing, we have much better medical therapy today than we did back then. So you'd like to think that all of the proven mortality benefits of things like statins and aspirin, the advent of PCSK9 inhibitors, beta blockers that reduce that ischemia, you'd like to think that the medical therapy would be even better. But really, that there's a paucity of data on this. So we're trying to sort that out.
So, Carl, that was absolutely fabulous. So I grew up in Cleveland, where the oculostenotic reflex built a lot of buildings at the Cleveland Clinic.
Yeah.
So in terms of thinking about a practical approach based on the degree of wall motion abnormality. So should we not send people to the cath lab, with mild levels of, wall motion abnormality? And I was also wondering if people went back to the COURAGE trial and sort of stratified the results, based on if there was appropriate testing, based on the level of wall motion abnormality.
I feel like I'm on NPR, and I have to try to answer that politically. Should we send people to cath lab or not? I think that there are probably a lot of times that we shouldn't. And that's different in ACS. I have to say, in the people that come in the ER and they get a stress test, that's a different boat. But in people that are in clinic with some dyspnea that you think you can blame on deconditioning, or that you think is probably COPD related, or maybe that are having some mild exertional chest pain, if you get a low-risk test, we probably shouldn't send them to the cath lab. Now, you do kind of wonder, if it's in the LAD distribution, are you going to detect severely abnormal disease if you go cath them, and then could you maybe give them the mortality benefit? But I feel really comfortable if it's inferior or circ distribution, and I know there are people in our group that do this even better than I do and say, I'm going to leave it alone, tell them I think this is positive, and then and work on meds. And what was the second part of your question there?
Just about if anyone has ever done a reanalysis of
Oh, not that I know of. The patients in COURAGE, though, were reported to have concerns for angina.
Congratulations. That's a terrific talk. And something you can expect from a magna cum laude in philosophy, weren't you? A magna cum laude in philosophy. But it boils down to that. I trained at that institution that was oculostenotic reflex at Cleveland Clinic. And, dye doesn't lie, stent cures everything, right? However, I think fundamentally what Dr. Richardson was showing us through the arc of history is that the illusion of knowability and controllability. The illusion of we can know everything, science can know everything and control everything. That's the new white coat syndrome, I think. So patients come, of course you can diagnose my cancer or PSA, or coronary artery disease, of course, right? And with 100% certainty. And one thing I've learned, the image that I like seeing is, Stanley Hauer was from Duke once said, if some uncertain things or strange things, or mystery, right? Medicine, human body is a mystery. It's like climbing a mountain, right? It's not that don't climb that mountain of aging, death, and all that, and say it's a mystery. Like, some people, anti-vaccinators or, no science, right? So you climb it, but know that at the apex, it's going to be misty. And have you ever been to White Mountain in New Hampshire? The weather changes on a dime. And we can't know it. We can know some prediction, some controllability. And Reverend Bayes, I think, was weather, right?
Yeah.
Ultimately, you can predict a little bit of it, short range more than long range. I spent a long time in statistics trying to predict things, and I'm a statistical heretic now. And controllability is the ultimate thing, predict the control. Now, this is going to be worse because the world is optimize me, algorithms and all that. Like patients come and optimize me. Optimize my cancer, optimize my CAD, optimize my aging, which really is Mount Everest. Okay, so how I view myself as an interventionalist is I'm just an interventional Sherpa, right? We help them at the peak of the mountain. I try to talk some of them to come down, it's clouds there. I try to lower the risk, and then, radial cath as opposed to femoral cath. And we've even percutaneous valve replacements. I never dreamed of that. But now we can do that. We can carry feeble clients to the mountain, but sometimes we say no go, or sometimes we say we need to hurry down. Now, but that's the issue you raised, that rabbit hole. What does that require? A different kind of courage to tell patients, look, you see white coats? Do you see 150-year-old white coats walking around? Or their parents or spouses? We don't know the secret. And then the other thing is time. That 15-minute return visit is just woefully. So what do? You order the test and go into that rabbit hole.
Were there any additional questions for Dr. Richardson? All right. Thank you so much. Don't forget to fill out the evaluation.